And now I'm pleased to welcome Dr. Helmy Eltoukhy, co-founder, chairman, and co-CEO of the Guardant Health. Dr. Eltoukhy, the floor is yours.
Cool, thank you. I'd first like to begin thanking the Royal Academy of Science International Trust and Rima Khan for the invitation to speak at the United Nations. Thank you, Madam Moderator, Dr. Carrillo Rivas, Your Excellencies, colleagues, and friends. With your permission, I would like to address the following important question. Where is the financing gap that prevents medical scientific breakthroughs from becoming globally accessible healthcare infrastructure? And how can public-private partnerships close that gap fast enough to even matter? Let me begin with a simple proposition that is obvious to every clinician and yet violated by the economics of modern healthcare. The earlier we intervene, the lower cost and more effective the intervention becomes. A cavity becomes a filling delayed becomes a root canal delayed becomes an extraction. Hypertension managed early becomes a pill, hypertension ignored becomes a stroke, in ICU, a lifetime of disability. Cancer caught early becomes surgery, often cure. Cancer found late becomes chemotherapy, hospitalization, and too often a countdown. And yet most health systems do not pay to find disease early. They pay to treat it late. There is a famous saying that it is better to measure twice and cut once. Yet we as a society have built a framework that reimburses intervention more reliably than it reimburses actionable measurement. We compensate procedures, admissions, and rescue. We undercompensate detection, prevention, and interception. The result is not healthcare, it is sick care, a symptom-based architecture that waits for suffering to become undeniable before it becomes billable. This is not merely inefficient, it is self-amplifying. When a system pays for downstream crisis rather than upstream clarity, it creates more crisis. The burden grows, costs accelerate, inequality widens, and the Sustainable Development Goals become harder to reach because health is a foundation beneath them. So the urgent question becomes, how do we shift from a symptom-based architecture to a signal-based one, from sick care to health care? The answer is not a single technology, it is leverage. For most of history, healthcare had remarkably little leverage. A doctor can only learn from the patients they personally see. A nurse can scale compassion, but not infinitely. Even the world's most skilled physician remains constrained by a single lifetime of experience, a single geography of practice, and a single set of cases that fate places in front of them. Now consider a different domain that the world recognizes as technology, autonomous driving. The best human driver on earth learns through one life, one pair of eyes, one brain. An autonomous driving system can learn from millions of cars driving simultaneously across continents, climates, and edge cases. Icy roads in Sweden, monsoons in Mumbai, fog in San Francisco, dust storms in the Middle East. Every near miss becoming data, every rare event becoming a lesson, every update distributed instantly back to the entire fleet. This learning is not additive, it is compounding. This is what leverage looks like, a tool that improves as it is used, because its experience is not bounded by one human lifetime. Healthcare is now approaching the possibility of that kind of leverage through AI, data-driven diagnostics, and robust signals from precise measurement systems. Signal interpretation engines across the fields of liquid biopsy, AI-enabled imaging, and continuous physiological monitoring through wearables that turn signal measurements into models, models into decisions, and decisions back into improved signal measurement. When a diagnostic system learns from millions of instances across hospitals, across countries, across diverse populations, it begins to behave less like a static test and more like an intelligence infrastructure. It can make detection earlier, it can stratify risk more precisely, it can guide intervention with fewer wasted steps, and it can do something that medicine has rarely achieved at scale, improve outcomes while lowering costs. But here's the paradox, and it's why this transition is so difficult. A symptom-based system is comfortable because it is familiar. It's also economically coherent. You treat what you can see, you bill for what you did. A signal-based system is initially uncomfortable because it pulls disease forward in time, exposing risk before symptoms, demanding action before crisis. It creates costs upstream so that catastrophic costs never occur downstream. It asks institutions and payers to invest today in order to save tomorrow. This is precisely why markets struggle to lead this transition on their own. The benefits of early detection and early interception often accrue to different stakeholders than the one who pay for the measurement. Prevention creates diffuse, delayed savings. Intervention creates immediate billable activity. In the language of economics, this is misalignment of incentives. It is language of real life, and it's why the world spends more to treat late-stage diseases than it spends to prevent it. Therefore, the shift from symptoms to signals is not only technological transformation, it is a policy transformation, and it requires public leadership. Public and governmental support is essential for three reasons. First, governments can build infrastructure when markets cannot. Just as roads, airports, and power grids were not financed one household at a time, early detection infrastructure will not be built one patient at a time. It requires coordinated investment in validation, deployment, standards, and access. And because a signal-based architecture is only as widespread, it must be designed for the whole population. Rural clinics, district hospitals, not only flagship medical centers. Second, governments can align incentives with long-term value. Public payers can reimburse actionable measurement, not merely downstream intervention. They can reward earlier detection when it demonstrably reduces hospitalization, disability, and late-stage treatment burden. They can build reimbursement and procurement systems that treat prevention as a public good, not a private luxury. Third, prevention is not only a moral imperative, but a fiscal one. In long-range budget projections, rising costs in major public health programs are repeatedly identified as central drivers of future deficits and debt, which means that bending the cost curve is not a rhetorical goal, it's a necessity. In the United States alone, national healthcare spending reached $5.3 trillion in 2024, roughly 18% of GDP, and public programs comprise a growing share of long-term fiscal exposure. In that context, earlier detection and earlier intervention, not simply better medicine, but may be the only sustainable path. And this is where public-private partnerships become decisive. Private companies are best at engineering learning systems, scaling manufacturing, building robust workflows, iterating software, and improving performance over time. Public institutions are best at ensuring that these systems serve the public interest, validation at population scale, interoperability standards, privacy protections, and deployment where the market would otherwise not go. In each case, the common theme is not the modality, it's the architecture. Actionable measurement first, intervention second. If we build a world that pays for measurement that prevents catastrophe, we'll not only improve health, we'll strengthen the SDGs. Because health is the foundation beneath SDG 1 on poverty, SDG 4 on education, SDG 5 on gender equality, SDG 8 on economic growth, and SDG 10 on inequality. A society that diagnoses late and treats late pays for sickness, not only with money, but with productivity and with lives. Excellencies, shifting from symptoms to signals will be painful in the way all paradigm shifts are painful. It will disrupt existing workflows, it will threaten entrenched incumbents, it will demand new reimbursement logic and new standards of evidence, and it will force us to confront the uncomfortable truth that many of our current incentives pay for sickness rather than health. But the alternative is far more painful, a future of accelerating costs, widening inequality, and preventable suffering. When healthcare learns not only from individual doctors, but from the collective intelligence of data-driven tools, when it learns at population scale across geographies and generations, that is when we finally acquire leverage. That is when medicine becomes not only a service, but a learning system. And that is when we can achieve the rarest outcome in public policy, better health and lower cost together at scale. So let me end where I began, with a phrase that names a shift and dare us to complete it. When signals replace symptoms, the first casualty is delay, the second casualty is inequality, the third casualty is a false trade-off between saving lives and saving money. Because when signals replace symptoms, we stop paying for suffering and start paying for foresight. We stop rationing expertise and begin distributing capability. We stop building ever larger hospitals to absorb the consequences of late detection and begin building learning infrastructure to prevent those consequences in the first place. When signals replace symptoms, we do not merely modernize healthcare, we rewire it. Thank you.
Thank you for your comments, Dr. Eltoukhy. And now I'm pleased to welcome Mr. Juan